Welcome to Leeds Fertility and our series of videos to help our patients prepare for IVF treatment with us. My name is Dr. Catherine Hayden and I'm one of the consultants and reproductive medicine subspecialists. Chapter 4 covers our success rates and the complications and risks of IVF treatment. So, starting with success rates. These charts show validated data which is published by our regulator at hfea.gov.uk. Leeds fertility is represented by the purple bars and the national average, as calculated by the HFEA from all the clinics in the UK, is in the blue bars. These figures relate to IVF and ICSI treatment cycles combined, where a fresh embryo was transferred. These embryos were created from the patient's own eggs, as opposed to eggs from a donor. Clinical pregnancy rates, CPR, means how many times a heartbeat is seen on the first pregnancy ultrasound against two baselines. On the left, the number of embryo transfers performed by the clinic in the 12 months being reported, and on the right, the number of treatment cycles started in the same time frame. The number of embryo transfers is slightly lower than the number of treatment cycles started because some patients will start a cycle but not produce an embryo for transfer. The HFEA wants to know how often this happens to make sure that a clinic is putting patients forward for IVF treatment appropriately and not undertaking treatment in futile circumstances. The most important messages from these figures are that the purple bars are invariably higher than the blue ones, which means Leeds fertility performs above the national average. In fact, Leeds fertility is in the top 5% of the 80 licensed clinics across the UK in terms of our outcomes. You can look at the bar for your age, that is the age of the female partner because it's the age of the egg that really matters, and get an idea of your chance of success in our hands. Success is determined by lots of things, but female age is the most influential. You can see that the bars for the age groups 43 to 44 years are starred because they're not very reliable due to the small number of patients treated in this age bracket. We know that more than 90% of a woman's eggs are genetically abnormal by this age, so the chance of finding a good one, amongst a yield that is likely to be small in the first place, is very slim indeed. It does happen occasionally, and those women who do succeed will invariably be on their second or third child rather than their first, as in they have a track record of good egg quality in the past. These figures relate to frozen thawed embryos and have the same denominators as the last slide: clinical pregnancy rate per embryo transferred on the left and per cycle started on the right. When Leeds fertility transfers a thawed embryo, the success rates are consistently above the national average. The chances that a transfer does not take place is low overall, 4% in our hands, or in other words, 96% of patients reach the transfer stage. Sometimes this might mean thawing more than one embryo, if there is more than one available. It's always very disappointing if only one embryo was frozen and then that embryo doesn't survive the freezing and thawing processes. This chart shows our live birth rate, or the chances of a baby being born alive once an embryo transfer has been made in a woman undergoing IVF under the age of 38 years, which is the age range most likely to succeed. We're proud to lead the field in our region. I'm just going to say a few words about time-lapse imaging and the EmbryoScope, which we have been using increasingly since 2014 at Leeds Fertility. This technology is categorised as AMBER by the HFEA traffic light system for IVF add-ons. The HFEA is rightly keen to protect patients from being charged for things that may not provide advantage. Leeds Fertility and its predecessors back to 1991 have provided a high volume of IVF treatment and a high proportion of NHS-funded treatment. The NHS cannot support treatments without evidence of effectiveness. We believe very strongly in an evidence-based approach to what we do. This means that proven science matters and makes a difference. Over the years, we have seen our success rate steadily improve because of this rigorous approach. We conduct research locally and participate in national and international trials to continually strive to make our treatments more successful and safe. Time-lapse technology has been a successful addition to our IVF programme, and we have contributed our experience to the scientific community for peer review. In our hands, as described in this paper published in the Journal of the Royal College of Obstetricians and Gynecologists, we found that the use of EmbryoScope technology increases the chance of a live birth by 1.28 times compared with not using it in culture to select the best embryo for transfer. We found that when a baby was born following embryoscope incubation, it was less likely to be born early and more likely to be of a healthy weight. Prematurity and low birth weight are associated with lifelong health issues in babies, children and adults. These findings and our overall performance as a clinic relative to our peers across the UK persuade us that this technology is providing an advantage. We believe that as time goes by and more research is done, peer-reviewed and published, that this technology will become more universally accepted as beneficial. We include EmbryoScope in our self-funded treatment cycle care package, but it is not included in the tariff we receive for NHS cycles. We're obliged to charge a supplement to those NHS patients who would like to use it. Please see our website for the current fees. The final section of this presentation explains some of the risks of IVF treatment. Generally speaking, IVF treatment is a safe process, but everything in life has some risk, and it's important that all patients are fully informed of the potential hazards of this treatment. The first and most significant risk is multiple pregnancy and the potential consequences of it. Fertility treatment developed a bad reputation in its first 25 years for twins, triplets and more. In 2008, the chances of having a multiple pregnancy following IVF was 20 times the natural incidence of twinning, largely due to the transfer of 2 or 3 embryos at once. About 25% of all IVF conceptions were multiples. The risks of multiple pregnancy are many, to the mother, the baby and the family unit, as well as society at large. For mothers, the pregnancy-related condition preeclamptic toxemia, which can be life-threatening, is 3 times higher in twin pregnancies and 9 times higher in triplets. The risk of pregnancy-related diabetes is also increased. Most worrying is the fact that having a multiple pregnancy doubles the risk of the mother dying in pregnancy. For babies, being a twin or a triplet increases the risk of miscarriage, both early in the pregnancy and late on, and also of premature delivery with its associated complications. The risk of cerebral palsy and disability are also increased. The risk of a baby dying within a month of birth is 5 times higher for a twin and 9 times higher for a triplet compared with a singleton birth. In 2008, the regulator of IVF in the UK, the HFEA, introduced the One at a Time initiative to persuade IVF clinics to bring their multiple pregnancies down to a target of under 10%. Leeds Fertility took this seriously on board. Our multiple pregnancy rate has been well below this target for many years now, without compromising our pregnancy rates. And as you can see from this chart, we're currently running at about a 3% multiple pregnancy rate. The chances of a pregnancy resulting from IVF treatment is closely related to the age of the woman and egg quality, as I have mentioned several times before, and to the performance of the clinic as a whole. Our figures show that if we have 2 good quality blastocysts available and we transfer both together, there's about a 50% chance of a positive pregnancy test, and then a 50% chance that that pregnancy will be a multiple, as in a twin. If we only transfer 1 embryo at a time, the overall chance of a pregnancy is less than 1% lower, so more than 49% overall, and the chance of twinning is less than 1%. 1%. This is a very small risk. There is a very small risk of a single embryo splitting to produce identical twins, so there's a small trade-off for a very large gain in safety by transferring embryos 1 at a time. The law permits the maximum of 2 embryos to be transferred in women under the age of 40 years. In women over 40 years, the maximum number permitted is 3 at any one time. And so I invite you to expect to have 1 embryo transferred in your first cycle of treatment, unless your cycle produces a disappointing yield and you are in the upper age bracket. The second most important risk of IVF treatment is ovarian hyperstimulation syndrome. All patients experience OHSS in a mild form. The risk is increased in women with polycystic ovaries, and we have a variety of specific measures for these women to reduce their risk, including lower doses of stimulation injections, a short protocol strategy, and a modified ovulation trigger. Overall, only about 1% of cyclists suffer significantly complicated OHSS. This would be symptoms that require hospital admission. We're always on the lookout and can often remedy the situation to allow treatment to continue safely. Occasionally, stimulation may need to be abandoned and restarted with a different dose or a different treatment regimen. Moderate OHSS can be aggravated by pregnancy, and so if we are concerned that you may be at risk of this, we may advise you that we freeze all the embryos from your fresh cycle. You will then get better over the next 4 weeks or so, and we can take you through a frozen cycle treatment as soon as you feel ready. You may be prescribed additional medications such as blood thinning injections as a precaution against serious complications such as blood clots or thrombosis. OHSS can feel quite unpleasant, producing some or all of these symptoms. Serious problems that may not be obvious to you include an increased risk of developing a blood clot or even kidney failure. We keep you under close surveillance, and if we feel that you are at risk, we keep you under close surveillance if we feel that you are at risk. But if you feel that something is not right, you should call Leeds Fertility sooner rather than later. We can give advice over the phone based on your reported symptoms or see you at short notice for assessment if necessary. Like most illnesses, it's easier to treat in the early stages. Please refer to your treatment diary for contact information depending on the time of day. With regards to the other risks of treatment, unfortunately, the chance of miscarriage is the same when a pregnancy has been created through IVF as when it comes about naturally. This is about 20 to 30% of positive tests, and these do not have the outcome that we're all working for. Most pregnancies are lost at the very early stages, often before anything is large enough to see on an ultrasound scan. Once a heartbeat has been identified, the risk of loss falls to under 5%. The risk of pregnancy loss may be increased for other reasons. I've messed up there, I'm afraid. Shouldn't have clicked on. Can I just start that slide again? It's all right.
Yeah.
With regards to the other risks of treatment, unfortunately the chance of miscarriage is the same when a pregnancy has been created through IVF as when it comes about naturally. There is about a 20 to 30% chance that... Oh dear. It's badly written, isn't it? That's why I can't read it.
You're doing quite well there.
With regards to the other risks of treatment, unfortunately the chance of miscarriage is the same when a pregnancy has been created through IVF as when it comes about naturally. That is, about 20 to 30% of positive tests do not have the outcome we're all working for. Most pregnancies are lost in the very early stages, often before anything is large enough to see on an ultrasound scan. Once a heartbeat has been identified, the risk of loss falls to below 5%. The risk of pregnancy loss may be increased for other reasons, such as advancing age of the woman, due to genetically poorer quality eggs, a relevant family history of a particular medical problem, and when the pregnancy is a multiple, as in a twin or a triplet. Ectopic pregnancies occur when the pregnancy implants somewhere other than in the correct upper part of the womb. The most common site is in the fallopian tube. IVF pregnancies can drift into the wrong place, just as naturally conceived pregnancies can. If an ectopic pregnancy is not identified, it may burst and cause serious internal bleeding, which can be life-threatening. The risk is greater when tubal problems have been identified. After IVF, we always do the pregnancy scan a bit earlier, at 6 weeks or 4 to 5 weeks after the egg collection date, to locate the sac, if not yet the active heartbeat, and therefore reassure you that you are not at risk of an ectopic pregnancy rupturing. There are other risks related to any kind of medical or surgical intervention that can occur with the IVF process. The risk of infection is greater if you already have fallopian tubes that have been damaged by past infection, or an active infection, or if you have endometriosis, especially in the ovaries, or internal scarring involving the bowel. We check STI screening for both partners in the workup to minimise new infection aggravating the process. The woman will also be prescribed antibiotic cream to use during the treatment. Internal bleeding and/or bowel injury are extremely rare but serious complications of egg retrieval. Despite all our efforts, and very, very rarely, equipment failure may lead to loss of eggs or embryos. Please be assured that the laboratory has very rigorous processes to keep all equipment in top-grade running order, 24 hours a day, 7 days a week, 365 days of the year. The regulating body, the HFEA, inspects all clinics regularly and sometimes in an unannounced fashion to verify that their code of practice is being adhered to. Untoward incidents must be reported to them and an inquiry follows to determine any causes or deficiencies. That reporting process includes informing the patient or patients involved. Transparency underpins trust, and it is vital that you can trust us with your care. It's worth saying a few words about the ICSI procedure and what we know about its safety. ICSI is an unnatural and invasive technique and may use sperm that would not otherwise have been able to fertilise an egg. ICSI has been used worldwide for over 20 years now. There have been potential concerns regarding the risk of passing on a genetic reproductive problem, particularly from male partner to male offspring. Studies so far are small and don't include the effects that may be seen in older children and future generations, such as the fertility of those children born as a result of ICSI. There is no clear evidence to date that ICSI results in more birth defects than those that occur under natural conception circumstances. There is also no clear evidence giving concerns about the physical and intellectual development of children born from ICSI. Finally, there is the ever-present risk that the treatment may not work for you this time. Sometimes the treatment process itself will reveal problems with an egg or with the embryo quality, which the treatment is not able to overcome. It's still very common for a pregnancy test not to result, about 50% of the time, when everything else has apparently gone really well, and sometimes we may have no explanation. In most cases, we suspect that the embryos were faulty in their genetic makeup and never destined to produce a baby. This is not something that we would necessarily be able to identify during the short period of time that the embryos are observed in the laboratory before they're chosen for transfer. However, it is the commonest finding when embryos are examined under research circumstances for their genetic detail. Genetic faults become very much more common as the eggs get older, and of course the woman that they come from gets older. By the age of 43, we know that more than 90% of our eggs are abnormal. Unfortunately, the IVF process is not the answer to this problem, unless younger eggs are used. You can find details about egg donation treatment separately on our website. There is still so much work to do to improve the likelihood of success, and we urge you to consider participating in any research projects that we may have underway at the current time. That concludes the final part of this series of videos preparing you for your IVF treatment, and I hope that you found it useful, helpful and reassuring. All of us at Leeds Fertility look forward to supporting you through your treatment and do sincerely wish you the very, very best of luck.